So I want you to imagine you're in the labor suit and the mother's just given birth to a child, and you notice the child has a swelling around their neck. As we look at the mother, she asks you what you think it could be. You look at her and tell her it could be a cystic hygroma. So welcome to Med One Pager. My name is Benjamin. Today I'm going to talk about the cystic hygroma, and this is one of another important tumors of the neck. So I covered a video about one of the important causes of neck swelling, and that is the branchial cleft cyst. If you haven't checked that out, please check it out. And today we're going to look at the cystic hygroma. So cystic hygroma is going to be a macrocystic lymphatic malformation. And from those words, you realize that it is a cyst. Yes, it is a large cyst, and it's getting the word microcystic because it's going to be seen to be greater than 2 centimeters in diameter. Lymphatic malformation that is coming from a malformation, embryological aberration in the formation of the lymphatic system. So it is part of a lymphangioma spectrum. And this means that we have a whole range of lymphangiomas. And we have the lymphangioma simplex, we have the cavernous lymphangioma, and then the cystic lymphangiomas. And then these lymphangiomas basically are vascular malformations. And when we look at vascular lesions generally, we have the ones that are going to, in the head and neck, we have the hemangiomas as well as the vascular lesions. The hemangiomas are basically benign tumors of perforating blood vessels. So these ones are going to be proliferative, and they're going to form blood vessels, and most of the time they regress with time. But then we have the vascular malformations, which can affect the capillaries, the venules, the arteriovenous system, as well as the lymphatic. So the cystic hygroma is going to affect the lymphatic. And this is going to be a benign but infiltrative lesion that grows by expansion, fluid accumulation, and local tissue infiltration. So what happens is that normally during the embryology, that is starting around the 5th week of gestation, we have the lymphatic system starting to form. And the lymphatic system is formed from the venous endothelium. And we have 6 primary lymph sacs. And these lymph sacs are the areas where the lymphatic vessels begin to grow out from. So we have 2 in the jugular area, 2 in the iliac area. We have the retroperitoneal ones and the cistern chyli. But what happens in cystic hygroma is that most of the time we have failure of the jugular lymph sacs to connect to the venous angles. Remember the lymphatic system is supposed to pour back into the venous system. So when we have failure of the lymph sacs formed at the jugular area failing to pour back into the venous system, we are going to have secretion of lymphatic tissue. That lymphatic tissue is going to swell, and when it swells, it's going to start forming isolated cystic channels. Those swellings are going to form that. Then we have defective lymphatic endothelial cells that are going to hypersecrete the vascular endothelial growth factor C, and when that is produced, it is going to encourage the growth of these more lymphatic cystic channels, and we're going to have a whole cyst developing. So when you look at the cysts that form, we have the macrocysts, and these are going to be greater than 2 centimeters in diameter. They are well defined and compressible. We have the microcysts. Microcysts are mainly going to be in the tongue and the floor of the mouth. You have the mixed lesions where we have a large cyst as well as this infiltrative microcyst. And when you look at the genetic factors associated, most of the time we have mutations that are affecting the vascular endothelial growth factor C or vascular endothelial growth factor R3. Then we have Turner syndrome. In Turner syndrome, we have lymphatic developmental arrest around the jugular lymph sacs. So when you look at the epidemiology of your condition, most of the time, the first presentation is going to be at birth. That is 50 to 65% of the cases. And majority of these cases are going to be diagnosed before the age of 2. And there's no sex difference. It attacks boys and girls equally. It is most common in the cervical region. And this is due to the location of these faulty jugular lymph sacs, which are most commonly affected. It is rare in the mediastinum and abdomen, but if it is massive there, it is going to compress a lot of vital organs that are within that area. So we have the risk factors that are and syndromic associations, as well as the chromosome abnormalities. The condition that is most commonly get to be affected, you have Turner syndrome, and that one is going to cause the classic large septated cystic hygroma, which is seen in utero. That is on ultrasound. Then we have the trisomy 21 with Down syndrome. We have trisomy 18, trisomy 13. We have the Noonan syndrome, Fringe syndrome, children with achondroplasia, though this is rare. And then we have the structural anomalies associated with this fetus. And these can be congenital heart disease, this can be renal anomalies, skeletal abnormalities, as well as polyhydramnios. And sometimes, when you look at the presentation prenatally, we may have hydrops fetalis. So when you look at the clinical presentation, you have the prenatal presentation. This is before the child is born. When you do the antenatal ultrasound, you find they have a bilobed septate cystic mass at the posterolateral neck. So this cystic hygroma is able to be in the anterior and posterior triangles of the neck. But when they see this bilobed septate cystic mass in the neck, they can suspect this African neutral translucency better than 3.5 millimeters. So it's a translucence around the neutral area, around the neck area. And sometimes you may find the patient has, or the fetus has hydrops fetalis. And then we can have pleural effusions, subcutaneous edema, as well as ascites. So this hydrops fetalis is different from the one that's associated with the blood group incompatibilities, the rhesus positive and rhesus negative mother. This is going to be a different kind of hydrop. And most of the time, it's the poor prognosis if one is diagnosed during the pregnancy, if it's within the first 12 weeks. If it is septate, it's also associated with the poor prognosis and recurrence. Then if hydrops fetalis is of course present, that also gives us a poor prognosis. Then we can do a fetal MRI, and this one's going to tell us the mediastinal extent. If there is airway compression, most of the time it will be helpful in making sure we have an exit plan. So when you look at the postnatal presentation, this is if the child does not present with it immediately. Sometimes the child may be very normal, they may start having this development of a painless soft flancular swelling in the neck or axilla. When you flash a light through it, it transilluminates brilliantly. So we have a transillumination, and this is pathognomic, and it is often ill-defined and multiloculated. You can really not tell its build does very well. And when the child gets an upper respiratory tract infection, or if there is hemorrhage into that cyst as well as infection, that is lymphangitis, we can have it expanding rapidly. And when it expands rapidly, sometimes it causes mass effects. So we can have things like airway obstruction happening. We can have dysphagia, drooling, sleep apnea, shoulder dysfunction if it's axillary, and we can have cosmetic disfigurement. And this is a very, very big issue. Then there's in the oral cavity, that is for the case of a microcyst. Sometimes you have this macroglossia, speech problems, as well as feeding issues. And all these things are going to lead to, when you look at the child's going to have failure to thrive because they're having issues with their breathing, with their feeding. Then we look at the investigations we can do. An ultrasound is the first line in infants and makes your multilocated cysts, thin septations, and preanechoic or debris-filled fluid. Then the MRI, we have T2 hyperintense multiloculated cysts, and where we can see, and the MRI is going to help us define the deep tissue extension, the relationship with the carotid sheath, cranial nerves, and mediastinal spread. A CT is not routinely used, and it's used when bone involvement is or thoracic extension is suspected. And the pre-diagnostic, how the prenatal diagnostics we can do include the amniocentesis for karyotyping, as well as fetal echocardiography to look for structural anomalies of the heart, because you have seen this, most of these kids have syndromic babies. So they may be having other structural abnormalities there. Then airway assessment can be done with a flexible nosoendoscope, and you want to also examine the cords and see if they are moving very well, or we are not having movements, issues with movement of the cords. So the management, the general principle is that it's going to be a multidisciplinary. You want to involve a pediatrician, you want to involve an ENT specialist, a pediatric surgeon, as well as the anesthesia team. And it's going to be individualized based on the size, the location, the symptoms, and the type of cyst. And sometimes we can do observation if it is small and asymptomatic, because some of these cystic hygromas may actually involute or go back to being small after some time. But then the first line therapy for the macrocyst is always going to be the sclerotherapy, where we go ahead and sclerose these lesions or obliterate them, and we have the 432, which is pasibanil. We have bleomycin, we can use doxycycline, we can use ethanolamine, or yet sometimes pure ethanol. We can use sodium tetradecyl sulfate, and these are all going to help. And the indications for this is if you have a macrocystic lesion, if you have unfavorable surgical anatomy, if it's in cosmetic sensitive areas. Most of the time, the complications you see with this sclerotherapy is fever, swelling, airway edema, as well as skin necrosis. Then we have surgical excisions, which you can do if there is airway compromise, if failure of the sclerotherapy, if you have cosmetic indication, as well as complicated lesions. And that is if we are having infections and recurrent bleeding, which causes this rapid enlargement of this thing. Then it can be adherent to vital structures, and recurrence can be there if there is incomplete excision. So if you do the excision, you have to make sure you remove the whole of it. If you don't, there will be recurrence. Then we have the laser therapy or the radiofrequency that is done for microcystic in the oral cavity, like on the tongue. Airway management is important and required if there is massive cervical lesions that distort the airway. And for neonates, we may need an exit procedure at delivery. I would like you to comment in the comment section if you do know what an exit procedure is. And if you don't, I'll still put it in the comment section describing or explaining what an exit procedure is during delivery. Thank you very much. This is Med1 Pager. Thank you for watching. If you like the video, please do leave a like, a comment, and share it with a friend. And don't forget to subscribe to the channel if you have not yet subscribed. My name is Benjamin. Till we meet again. See you next time.